All right, well, let's go ahead and get started. We are recording the webinar today, so if you have a colleague who wasn't able to join us or who is unable to attend the subsequent session next week and wants to be able to watch that online, we will have a recorded version of that, so just let us know if you'd like a link to that. We're happy to share it with you. But thank you again for your time today. Again, my name is Matthew Menendez with White Plume. I'm excited to be talking about the work that we've done with SRS and their new APIs recently, and kind of sharing that with you. I'll walk through a demo of that as well. But what I want to do first is kind of tell you what I hope to accomplish today. We're going to go through a lot of information. I'm going to try to move through it quickly, but let me tell you what we're going to be accomplishing today. The first thing that we want to do is we're going to be talking about better data, right? The need for better data as we make the transition from volume-based reimbursement to value-based reimbursement is going to be very, very important. Medicare and commercial payers are pushing towards being able to measure and pay and publish data on cost and quality. Those are the two big things that they care about: quality outcomes and cost efficiency. And we need to have better data in order to be successful in that world. In order to be measured accurately in that world, we need to be able to have better data. But we also don't want to make the mistake that we've made over the last 6, 7, 8 years during the meaningful use era of slowing down and turning doctors into data entry employees. We want to do that with as few clicks as possible, capture better data faster than we do today, and then automatically routing that data both to SRS for the clinical information and to the practice management system to get the claim paid. I'm going to show you how we do that with AcceloCapture to launch that data from AcceloCapture into both SRS and your practice management system. I'll show you how we do that. I'm also going to talk about our powerful rules engine. What the rules engine does is it enables you to have better revenue cycle outcomes and spend less time to do that. Right? That is essential as we move into a value-based reimbursement world. There are going to be new tasks, new work that's required of your practice in order to be successful. And there are no additional dollars to do that. So it makes it hard to hire additional staff, right? So I'll show you how our rules engine, we call it AcceloSmart, is a very, very powerful tool for improving revenue cycle outcomes and spending less time on those processes. And then I'm going to share with you some successes that we've had with SRS and White Plume clients working well together. Right? The thing that we hear, typically the two biggest things that we hear from our clients, and we work with over 40 practices that use both SRS and White Plume, is we should have done this sooner. This makes so much sense. I wish we would have done this years ago, right? And then number two is, can you please send the diagnosis data back to SRS so that we don't have to enter it twice? I'm glad to say that the answer is yes, we can. We can send that data back to SRS, and that's very valuable. That's what I'm going to show you here today. I'll make sure that I leave time again for questions and answers at the end. So thank you again for spending the time with us this morning. I hope this will be helpful for you. If you're just joining us, welcome. Feel free to use the questions panel to chat any questions, and we'll try to answer as many of those as we can, either as we go or at the end, whatever seems most appropriate. All right, so let me tell you, just when I think about better data and I think about value-based reimbursement, I think it's helpful to get the big picture. So I'm going to zoom out for just a second and talk about what is the government doing, what's going on with macro, what's going on with MIPS, so that you get a feel for what this actually looks like, okay? And so what's happening with PQRS, value-based modifier, meaningful use, all of the government programs, what they're really trying to do is their goal at the end of the day is to accomplish the triple aim of healthcare, right? That's what they're trying to do, and that's generating better health outcomes and doing that at lower cost and an improved patient experience. That's the triple aim, and Medicare knows they can't do this on their own. This cannot be, they cannot just sit as the payer or sit as the government and accomplish this without involving patients and without involving providers, right? So what we see is over the past couple of years, and they'll continue to do this, is shifting risk. Shifting risk from the payer to the patient, from the payer to the provider, to engage them in this dialogue and get them involved, right? That's what's happening. And you've seen that probably in your own employee health plans. We've certainly seen that here at White Plume, is where we're starting to see higher premiums, we're starting to see higher deductibles, right? That will continue. That's probably there's no near-term end in sight for that. But you're also seeing patient engagement, right, through patient portals. You're seeing the idea is to, as you get more and more of the financial responsibility on the patient's back, they tend to make different decisions. And that's trying to engage them in that long-term goal of accomplishing the triple aim. Okay? And at the same time, you also see risk shifted over to the providers, right? That's what the MACRA and the QPP and APM and MIPS is all about, right? It's trying to make sure that that gets done correctly, all right? So you'll continue to see that. Sometimes I get questions on this about, you know, what about the new administration? How much of this will change? That's certainly a question mark. You know, that it's always difficult to predict the government, and that continues to be true. But what I think I would say to that is that Medicare, as it operates today, is unsustainable, right? We have 10,000 baby boomers that are new enrollees in Medicare every day right now. And we have to be able to, if we're going to be successful in sustaining Medicare, there are changes that are going to have to be made, right? That will continue to be true. I don't think that the administration will back away from some of the long-term Medicare plans. You know, but I could always be surprised by that. And I think that's a legitimate question to think about. So I hope that's helpful. Let me show you kind of what Medicare's long-term plan on this is, because I think that's helpful. They've got some dates out there and some targets out there of what they're trying to do. And when they look at value-based reimbursement, they put that into 4 different categories. And let me try to explain each of these. Category 1 is just straight fee-for-service. That's what we used since 1965, and fee-for-service is not going away entirely. The category 2 is what you see, fee-for-service linked for quality, and that is where most people are today, right? That's what PQRS is about, linking fee-for-service and quality. That's what the value-based modifier is about, linking fee-for-service to quality, all right? But the goal, obviously, is long-term to be able to move people over to Category 3, move people over to Category 4. Here's where we are from a distribution perspective right now. You see most people are in Category 2 in 2016, with 30% in either Category 3 or Category 4. The goal by 2018 is to move that number up to 50%. That's a significant change in a pretty short period of time. Most of those people will be in the Category 3 space. And when you look at what they're trying to do, it's all about measuring cost effectiveness and quality. We've seen that in the old Medicare programs. We see that in the new Medicare programs. And let me show you what that looks like. Many of you may have seen this. This is a QRUR report. that comes out of the old value-based modifier program. And what they're trying to measure, as you see on the vertical axis, they're measuring cost, and on the horizontal axis, they're measuring quality. On your individual provider QR/UR reports, the red diamond is you, and all of those blue diamonds are other providers. And so you're being measured on cost, measured on quality relative to your peers. Nobody wants to be in the low quality, high cost, that lower left quadrant there. That's not a good place to be. That's where you get the penalty. Everybody wants to be in the high quality, low cost, top right quadrant, right? That's what they're measuring. That's what they care about. And as you fast forward and you look at MIPS, you look at the 4 different categories of MIPS, you'll see cost and quality are always equal to 60% of the MIPS score. Right now, I don't have time today to go into all of the details that are associated with MIPS. You know, SRS does some great webinars on those as well. We've done some webinars on MIPS. If you want some additional information on that, we've got recorded versions of those webinars we're happy to share with you. But I hope the point that I'm able to communicate to you is better data is going to be required to be successful in the transition to value-based reimbursement. We're going to need better data than we need today. And most of that data is talking about cost and quality, right? And it sounds so simple of what Medicare wants to do. They want to start measuring and paying for cost and quality outcomes, right? And the pushback has always been and continues to be, but you don't understand. I treat some of the sickest patients, right? Of course, they're going to have higher expenses. Of course, their outcomes aren't going to be as well. These are the patients that we need to serve the most. And CMS has said, okay, we will make these types of measures risk adjusted for patient acuity. But you've got to be able to prove it in the data. You've got to be able to prove it in the data, okay? And the way that they are doing that risk adjustment are through HCC scores. Now, I'm going to go through this part quickly. If you want more information on HCC scores, we can direct you to that as well. But HCC scoring, HCC stands for Hierarchical Condition Categories. They were originally created in 2004, and the purpose was for capitated Medicare Advantage plans. The Medicare was paying these Medicare Advantage plans a per member, per rate, per month amount, and the Medicare Advantage plan said, hold on, time out. These are some of the sickest patients. We need to be paid more for them than the average Medicare beneficiary. So the HCC score is used to measure patient acuity and project future healthcare expenses for that patient or that patient population. So that's what's used for risk-based adjustment. Now, you notice that was started in 2004, so this is the 13th year of HCC codes, and it is the preferred Medicare risk-adjusted methodology. It's used still for Medicare Advantage risk adjustment. It's used for the hospital value-based purchasing. It's used to measure transfer payments under the ACA exchange plans. That's between payers. And commercial payers have adopted this as well. They use this for their risk-adjusted plans. Now, what we found, most people have not started using risk-adjusted plans yet. That's still something that's relatively new. We've seen maybe about 18% of our clients out in the marketplace who have commercial risk-adjusted plans right now. We expect that will continue to go up, right? Over time, you'll see more and more of that. But mostly that is large multi-specialty groups who have been approached by a commercial payer asking to kind of enter into a risk-adjusted plan. So if you haven't seen that yet, I expect that you probably will over the next 2 or 3 years. So let me explain how those HCC scores work. there are two components to the HCC score. There's demographics plus diagnosis equals HCC. So the demographics portion is relatively straightforward. Age, gender, and eligibility status. So if you're older, you're going to have a higher score. If you're dual eligible for Medicare and Medicaid, you're going to have a higher score. Okay? The diagnosis portion is they use the diagnosis codes for that particular patient for the past 12 months. Okay? So this is all of the patient's diagnosis. So if they saw a primary care physician and an endocrinologist and a cardiologist and an orthopedic surgeon, they gather those across the patient because Medicare as the payer has access to all of that data. You know, unfortunately, they do not share that information with the providers in real time, right? They really should, but they don't. So that is a patient-centric view of what that particular patient looks like, okay? And then they use that HCC score as a multiplier, right? So the average HCC score is 1.0. So 1.1 multiplied times the average cost per beneficiary of about $9,000 says we expect that patient to cost $9,000 next year. So if you have a higher score and you have a sicker patient, that means we expect to have a higher projected Medicare expenditure over the next 12 months, right? But let me give you an example. I think it may be helpful to look at it this way. So if I've got a 76-year-old patient who is dual eligible, right? Those two factors right there, what that means is that her HCC score, 0.0593, Medicare only expects to spend just over $5,000 on that patient over the next 12 months, right? You see how that works? So if her HCC score was a bit higher, then we would expect to spend a bit more. That's why it's important to make sure that we're capturing these comorbidities. And let me show you how that impact actually comes into play. So if what I do is if I capture some more detail on this particular patient and capture that diabetes diagnosis, you'll see the HCC score increases, the average Medicare expenditure increases as well. But it still hasn't painted a full picture of what we expect that patient to look like. If I code diabetes with complications of vascular disease and congestive heart failure, now you see that Medicare expects to spend almost $10,000 more on that patient over the next 12 months than if that patient only had diabetes without complications. Right? And that's just on one patient. You multiply that across your patient population, and you can see how the numbers really start to add up. So the frustration is often, I understand that my patients are really, really sick. I know what my patients look like. I know the complications of trying to treat these patients. But Medicare and the other payers, they think my patients are relatively healthy. How do I explain the difference between those two? Well, it's what I code, right? They're using that claims data to get a picture of what that patient looks like. Let me give you another example of kind of how this plays out. I think it's helpful to see the example. Let's say I've got 3 identical patients who all need total knee replacements, right? I get paid for the CPT codes. Forever and ever and ever under fee-for-service, all I needed was a diagnosis code that makes it medically necessary in order to get that claim paid. So in patient number 1, if all we code is osteoarthritis of the knee, that patient looks relatively healthy to the payer. Right? If I code the comorbidity of morbid obesity, right, now that we've got a more accurate picture of that patient, but it's still not complete, right? Because the patient also has type 2 diabetes with polyneuropathy. Now, if I code that complete encounter, that looks more accurate, right? And you can see the HCC score is very different for those patients. The first two look like a healthier than average patient. And so that means they're adjusted in the expected Medicare expenses. We expect to spend less on those patients than the average Medicare patient. And on patient number 3, Medicare expects to spend more on that patient than the average Medicare patient. Meaning those 3 patients are identical. The only thing that's different are the diagnosis codes that we used to communicate fully to the payer what that patient really looks like. And that's why it's important to get that done correctly, right? Now, I realize most people don't do this today, right? A lot of people don't have risk-adjusted plans. A lot of doctors, and I borrow this slide from Blue Cross Blue Shield plan up in Michigan because I think it paints a good picture of the mindset that a lot of people have. That's why we want to provide some education on this. So I'm going to go ahead and launch our first poll question and just answer as best as you can. That what best describes the way that your doctors are documenting and or coding those comorbidities today. Most of your doctors are documenting and coding it. Most of my doctors are documenting but not really coding it, and most of my physicians are not documenting that at all. If you're not sure, that's okay. We've got a choice for that as well. So click on the one that best describes the majority of your physicians. Typically what we see is there are only about 18 to 20% of the practices out there that say their doctors do a good job of both documenting and coding it. We're right on track for that today. Just to give you kind of an idea of where other people are, you know, I think that's helpful, helpful to know. So thanks for participating in the poll. Hopefully that makes things fun for all of us, keeps us moving through our time today. So let me give you just a quick series of points as to why we think it's important to capture that data, right? Why you want to make sure that you do that, even though it feels like another thing to do. We're going to talk about how to capture it quickly. So I'm going to go through that process as well, but I want to talk about why it's important to get those comorbidities done. The first thing is we obviously want accurate fee-for-service reimbursement. You've got to have good quality data in order to get the claims paid completely and correctly the first time. We know that's important, right? But we also want to make sure that we're accurately capturing those comorbidities to reflect patient acuity, right? And we're going to be measured on those cost and quality measures, and those are going to be risk adjusted. We want to make sure that that's done correctly, because otherwise we've just set ourselves up for a very difficult measure, right? If your patients are actually really sick and you're showing to the payers that they're really healthy, that's not really a fair measurement, is it? Right? That's not a fair measurement because it makes those patients look healthy and it makes your quality scores look worse. It makes your cost scores look worse, and that's not what we want, right? That's not what we want. So we want to make sure that we capture that data correctly. Another thing that I've heard some clients talk about is that the data doesn't look right in their patient portal, right? That was one of the things that everybody was trying to do for meaningful use, was get the portal set up, walk the patients through the process of getting logged in, and then when they did that and the patients actually got there, one of the things that they would see and that they would notice is that their data didn't look right. They'd say, well, that's not a complete list of all my diagnosis codes. What's going on here? This practice doesn't know what's really going on with me, when that couldn't be further from the truth. The patient knew exactly what was going on with, the doctor knew exactly what was going on with you, but the data just wasn't complete, right? They were entering one diagnosis into the EHR to satisfy meaningful use, and that's what was being fed to the patient portal. That's what makes this tricky, right? We want to capture good, accurate data so that our patients have access to that. Medicare is trying to publish this data on Physicians Compare websites. Again, don't have time to go into all of this today, but Medicare is trying to publish this data on quality, on outcomes, on cost, and nobody wants to have a Google search for their practice or their doctors showing them as a low quality or high cost provider when in fact they are an excellent physician. The issue is just that they haven't done the risk adjustment correctly. Blue Cross, Aetna, Humana, United, they're moving towards risk-adjusted plans as well. We need to have that type of data, right, so that you're prepared for when they start doing that in your area. And the last part that I think is very helpful is having the data to know what those patient populations look like for your individual payers, right? What that means is the insurance companies are collecting this data today. They know how sick those patients are. And if they come to you and say, hey, you know what, your group did 200 total knees for us last year. We'd like to talk about a volume discount on that when it's time to renegotiate that contract. It'd be great to be able to say, hold on, Blue Cross, your patients' HCC scores on average are 7% higher than my United plan. And what that means is those are the patients that are most likely to have a readmit post-op. Those are the patients that are the most difficult to treat. I should be charging you more, not charging you less. That completely changes the dynamic of the negotiation with the payers. They have access to this data. You need to start tracking this as well. All right? Now, I know I've moved through this quickly, but I wanted to spend time talking about the need for better data because that's a big part of where we're headed. And we want to do that faster than we do today, right? Doing that faster than we do it today is very important. And I'd like to talk about a couple of things because what we know is that our patients don't want our doctors to be data entry machines. That's not good for patients. That's not good for our doctors. We know that we need the data, but how do we do that in a way that makes sense for everybody, right? This is not rocket science. Let me share with you just some very common sense that came out of a 2015 study by the Journal of Participatory Medicine asking about what do patients really want. You know, what do they want from their doctors? They want a doctor who listens, who's caring and compassionate, who explains well what's going on with them, right? What they talk about is the interaction between them and the doctors. And if the doctor is busy trying to capture a bunch of data or put a bunch of information into the computer, that usually doesn't go well, right? And we know that that's not what the physicians are after either, right? Physician burnout rate is at an all-time high. This is a Mayo Clinic survey that was done in 2015. Again, not new information to anybody, but from 2011, the purple bar, to 2014, in every single specialty, physician burnout rates increased. Physician burnout rates increased during the meaningful use era that we're finally coming out of, right? The government regulations that were imposed on vendors, that were imposed on practices, right, had significant cost in the industry. EHR vendors were told what they need to build into their next release to be certified. The development schedules were being driven by Washington, not by clients. And on top of that, the government workflow that was prescribed required you to capture data that really wasn't meaningful, that you really didn't care about, that really wasn't necessary, particularly for specialists. And now that we're finally coming out of that, we'll get some flexibility in MIPS about how you want to participate, what you want to do. You need to take advantage of that flexibility. Take some of that control back so that we can spend less time clicking and more time with patients, all right? The flexibility that you get in MIPS is really, really good. Again, can't go into all the details of this today. We did another webinar on MIPS, but everyone should be able to submit something, that second option, for the transition year in 2017 to avoid the negative adjustment. But MIPS is not all or nothing. You can choose how you want to participate, where you want to participate, what makes the most sense for your practice. And that's where we think we've got some opportunities to make things better for your group, to capture better data and do that faster than we do today. And let me show you how we've leveraged the SRS APIs to make that better for your practice. All right? I'm going to give you the workflow overview here, and then I'm going to jump into the live demo environment so that you can see how that works. What you see on the far left of this screen is ExcellaCapture. It's an electronic super bill that we custom design for every single one of our clients. We can get that down to the subspecialty level, or even for individual doctors. We make that look exactly the way that you want it to look so that it's fast and efficient. Now, it's not always the physician that has to complete that. We see plenty of practices where they have a PA or an MA that are helping them with that. They capture that data, and we're going to send it to two places. We're going to send the clinical information, the visit type, the diagnosis codes, back into SRS so that that can post in real time. And then we're going to send the financial information, the billing data, to your practice management system so it can go out on a claim, right? But what we're going to do first, before we send it to the practice management system, is send it to a revenue cycle application called ExcellaSmart, very powerful rules engine to make sure that we optimize the revenue cycle, right? Capture data one time, have it go where it needs to for clinical and for financial at the same time, all right? So let me show you how that works. I'm going to change my view here for you. So I've got a patient, Emily Plume, that's in SRS. Many of our clients have a polling folder, a power tab at the bottom of SRS. And what that does is it automatically launches that patient's electronic super bill. Right? SRS passes us the user information, the patient information, so that you don't have to choose that patient in two systems. So, some of our clients even think this is a part of their SRS application because it works well together. All right, so if I say I've got a level 3 office visit, right, pretty easy, one click and I'm done. I flip over to the back side and I've got my diagnosis codes, right? So maybe I've got a patient that has lower back pain, and I also want to do, let's say I'm going to do a degenerative tear of the lateral meniscus, and I get this pop-up. This pop-up lets me choose the right diagnosis code. It makes it easy for me to see it's a derangement of the lateral meniscus due to an old tear of the left knee. One click and I'm done. One really cool thing that our clients like, some clients have added in a comorbidity section to make it easy for me to also say, yep, it's also morbid obesity and hypertension. So I'm capturing some of that HCC data and doing that in a very easy way. When I'm done, close that out, and I click complete. When I click complete, it does three things. It closes that electronic super bill, saves all the encounter data. Right? I'm back into SRS. Right? It's going to send that data to SRS. So the next time I refresh this patient, what you'll see is I'll see all that diagnosis information show up, and I'll see the visit type pop up. All right? Oh, I got a problem with the way I saved that diagnosis information, but I'll come back to that, fix that before we get to the end here. So that takes the data, easy to capture in one view there in ExcellaCapture, sends it to SRS so that you've got all the information there in the chart, so that it's populating the patient portal with the accurate information, the diagnosis codes, all the comorbidities, right? And it's going to route all of that data to your practice management system to automate the data entry process, all right? So let me stop right there and ask another poll question that really, how are you capturing that charge data, that encounter data today for your billing process? Are you doing that through charge passage? Do you have a paper super bill or a paper encounter form that somebody's using to capture all that data so it can get keyed into the practice management system downstream? Do you have people that are coding from the note, the documentation, whether that's dictated or going through the template? We do have a couple of White Plume clients that are on, so that you don't have your option since this was generally for non-white plume clients. So I'm sorry we didn't put a Excel capture option on there for you. But just to pick the one that at least describes the majority of your encounters. If you've got a mixed environment, choose the one that's most appropriate for your practice. That would be appreciated. Okay, let me move on. I'll close the poll. Thank you for participating again. We talked about the need for better data, and we talked about the need for capturing it faster than we do today, and how the APIs that SRS developed that we work together on really help you do that. Let me spend a little bit of time talking about the rules engine, because the revenue cycle is very, very important, and we're going to need to continue to be very efficient and effective at that. And so let me show you how our clients do that. What we want to do is we want to do three things with this rules engine. Number one, we want to make sure we don't turn our doctors into coders. That's not what they're best at. That's not what they enjoy doing. And that's not good for the business. So we want to make sure that we don't turn our doctors into coders. The second thing we want to do is we want to generate better coding outcomes, better revenue cycle outcomes in less time. I'll show you how our clients do that, so that ultimately at the end of the day, we can reallocate that saved time to higher value tasks. What we found is, on average, we can save one full-time equivalent for every 6.5 providers in the practice, just by automating the data entry portion. And those functions can be reallocated to other higher value tasks that need to be done in order to be successful in the value-based reimbursement world. All right, so what ExcellaSmart does, it captures all of the encounter data. It lets you review that in a batch, which automates the charge entry function. So I'm not reviewing every single encounter, and I'm not making my doctors or my clinical staff do this. I'm doing this after the fact. And I can do that on an exception-only basis. So I don't have to review every single encounter in this batch. I only have to look at the ones that have problems, right? And what that allows me to do is spend less time, right? Our average user can process 120 encounters in an hour because they only have to look at the ones that have problems. That lets me spend more of my time on higher value functions so that I can prevent denials before they ever happen, right? I can see things that say, hey, hold on, you can't build these two CPT codes together. Wait a minute, we left off a modifier because my doctors don't pay any attention to modifiers, right? That lets me prevent these types of denials. The other thing that it lets me do is build in rules that are specific to my payers. Some of our clients are great at this. They're even able to find missing charges. Hey, you know, we billed for the casting services, but we didn't bill for the Q code here because we forgot. We left that off. We made a mistake. If I've got an automated tool that's very, very powerful, it allows me to catch that every single time. So I can bring my denial rate down, I can capture missed charges better, and I can do all of that in less time than I do today. Right? That makes sense? That's what we're doing with that rules engine. And then we can run some analytics on top of that that allow us to get even better. Let me share some of this with you, some new reporting that we've been doing for some of our clients that looks at my revenue cycle employees so that I can have some data on who are my all-stars, right? I'm not just looking at batting average. I'm able to look at some advanced statistics and say, you know what? I see two things on this report that really stand out to me. Number one, they're touching a lot of encounters. They're having to make changes on nearly 90% of the encounters that flow through my rules engine. That says I've got a problem here. What's happening? This particular client captures charges through a traditional point-and-click EHR that generates a bunch of coding work for them on the back end. So they know that they're willing to do this because they don't want to turn their doctors into coders, and the EHR system that they use is kind of clunky on that. So they've got some room for improvement there, right? But even with that high touch rate, they've got a couple of employees, or 3 employees in particular, that are really, really fast, even with a high touch rate, right? So those top 3 employees are doing the majority of the work, but they're doing it 3 and 4 times faster than their peers. So this lets us talk and figure out what those employees are doing really, really well, so that we can translate that to the other users, so that we can make them faster, so that we can reallocate some of that time, again, to higher and better uses. Does that make sense? So not only have we automated the process, but we've got some analytics and some tools that let us go back and refine that and make additional improvements and additional gains with very, very little additional cost. Another thing that we noticed in some of this reporting for another client is we were looking at the types of changes that they were making. Right? They were having to add some diagnosis, delete some diagnosis, but that gray bar, the other procedure changes, was very interesting to us. And so what we found there was that there were 899 changes that they were having to make in about a 30-day period of time. And what that was, what was happening was that they were actually changing the CPT order. They were changing the CPT order on encounters. And what that meant was that they had E&M codes that weren't the first line item on some particular encounters. And the issue with that, what was happening was it was the way that their EHR was capturing the data. They were having to manually go in and reorder those. So we talked to them and said, you know what we can do? There's some things that we can do that will automate this particular process. And so we were able to automate something that the users were doing 30 times a day, every single day. And again, that allows us to reallocate some of that time, again, back to higher and better uses. All right. The last thing that I'll show you on that front is they also look at their individual providers to see how they're doing, what volume of encounters they're making, what types of changes they're having to make, so that they can show the doctors, here's all the work that we're doing for you on the revenue cycle side. We want you to be a doctor, not a coder. That's why we're doing this, right? And where are the places that we can build into that electronic super bill a faster, more automated way to make sure that we not trying to put work onto the doctor and off of the coder, but a way that we can make sure we have better revenue cycle outcomes and that we spend less time to deliver those types of outcomes, right? That's why we think we need better data faster than today, and we can leverage that powerful rules engine to generate better revenue cycle outcomes as well, right? This is not something new. This is not something that's unproven. We've been working for a long time with SRS. Since 2006, we've been partners and work with over 40 different practices and 1,300 different providers to make this work in their organizations. The ROI is significant and very quick. It depends. It's different for each practice. But if we make an assumption for a 15-doctor practice, and each of the providers see 30 patients a day, right? The value from the automated charge entry, and I'm just talking about automating the entry to the practice management system. This is probably a bit conservative, because if you've got somebody that's after the fact entering some of this information to the EHR, we can automate that process as well. It pays for the system in and of itself, as does a 2% improvement in your denial rate, right? We can typically see that with the rules engine. It depends on where you start from today, but there's opportunity for improvement there as well for the additional revenue. For a 15-doctor practice, total savings of over $15,000 a month is significant. I would encourage you to talk with other practices. There are lots of them about what their experience has been with White Plume. Here are some of the things that we hear our clients say is the help desk is awesome. Whenever we have problems, we call in and they get back to us so fast. It's great. They do a wonderful job. I wish I would have done this sooner, right? Right now, because of the new API partnership with SRS, we are looking to bring on some new clients who want to take advantage of this advanced functionality. If that's something that you're interested in, and you want to do that in the first quarter, and for a new agreement, we're able to do the first 2 months for free. So hopefully there'll be some people on the phone today who want to take advantage of that as well. And again, the thing that I hear over and over and over again, particularly from SRS clients who have been around for a while, is, gosh, I've known about White Plume. I really wish that we would have done this sooner. So if that's you, if you've been thinking about that, and now adding in this API gives you another layer of value, call us up, let us know. We can schedule a more detailed demo for you. I am going to go back real quick to that live demo environment, because it was not pulling in the diagnosis before, so I got that fixed. So what you'll see is when I click a diagnosis here, after I hit save, I can pop back over to SRS. When I refresh it, you'll see it pop in this diagnosis section right there at the top. So that is a real-time API that'll take that data out of Capture and put it into SRS as well. So I'm sorry for my demo mistake earlier, but I know we're quickly coming out of time. But let me remind you about what we talked about, and then I'll try to answer as many questions as I can. We think it's really important to have better data. It's important to accurately show how sick your patients are. It's important to know what your patient populations look like by payer, so that you have better negotiating leverage with them when it's time to renegotiate that contract. Medicare, the commercial carriers, they are paying attention to the HCC for risk adjustment, both for quality and for cost measures. You're going to see more of that over the next 2-3 years, not less. But don't do that in a way that's going to slow down your doctors. What our patients need are doctors that are paying attention to their needs. And what our doctors want to do is to take care of patients, not to be data entry machines. Excella Capture allows you to capture that very, very quickly with just one click, and it'll send it to both SRS and your practice management system. That, in the combination with the rules engine, gives you a very, very strong return on investment that's been proven by many, many other practices that are very similar to most of the people on the call today. So I hope that that's helpful. I know I went through a lot of information, and I did it quickly, but let me open it up for questions. I'll try to answer as much as I can. So if you've got questions, put those in the questions panel, and I'll go through those. If you have follow-up information that you'd like a link to the recorded version, if you would like the copy of the slides, if you'd like more information with like a more detailed follow-up demo, feel free to put that in the questions panel as well, and I'll make sure that we get that to you also. Hold on, I lost my questions panel. Okay. Shelley's already answered a couple of these. That's great. Somebody said the diagnosis input. Yes, I made that mistake. Hopefully you guys saw me correct that later. Let me know if I need to go back and do that again. I'm happy to do it a third time. Somebody was asking the question about Excella Capture. What are the costs for Excella Capture and Excella Smart? Generally, it's licensed on a per provider basis. It depends on how many doctors you have and if there are other parts of the solution that you need or what types of interfaces you need. But in general, when we kind of look at that, talk about the return on investment, and we can put together a customized return on investment for you. But if I bring that screen back up, typically what we see for a client of this size, that's pretty straightforward with the practice management systems that they have. They'll have a software cost of less than $2,500 per month. and the startup costs are less than $10,000. So the return on investment for them is within the first month and a half, the software has paid for itself. So very strong, return on investment there. And we think it's very, very easy for physicians to learn. Somebody asked a question about that. Let me answer with just a quick story on that. I was talking to a physician last night who's joining a practice that's a client of ours. It's a neurosurgery group, and he had never seen Accellacapture before. He had, obviously used a Superbill before, but had never seen Accellacapture. The administrator said, well, we can get you some training on this. I'm sure White Plume can do that for you. And after he looked at it for about 5 minutes, he said, I don't need that. I don't need it. I know how to do it. That'll be fast and easy for me. No problem. So one of the things that we have found is if we can make that electronic Superbill look very similar to what you're using on paper today, it makes that transition very easy for the physicians or the MAs or the PAs, whoever's helping with that. It makes it very fast for them to fill out that encounter form. All right, I think all the other questions look like they are pretty specific to individual groups, so we'll handle those offline. But thank you again for your time today. I hope that this has been helpful for you. There is a very short 3-question survey that you'll get when you leave the webinar. It takes probably 30 seconds to fill it out. That feedback is, I look at every single one of those. They're very helpful for me to make my webinars better going forward. So if you don't mind filling out that survey, I would greatly appreciate it. Thank you so much. I hope everybody has a great rest of your Thursday. Bye-bye.